So good day, friends. This is Dr. Bob Hamilton, and you have tuned in today to the Hamilton Review, where kids and culture collide. Thank you all for being there. It means a lot to me, and I want to encourage you, if you like what you hear, pass it on to your friends and family. I know that each of you are zipping around in your cars, busy people doing different errands. I know that because I have kids and grandkids and a wife, and I know what they do all day long. So it means a lot that you tuned into this podcast. So thank you for that. And I say thank you for the people that come on my show, because they're the ones I want to highlight. And today is no exception. It's a pleasure, such a pleasure to welcome today Dr. Steve Hodges to the podcast, to the Hamilton Review. Who is Dr. Steve Hodges? He's a professor of pediatric urology. He's back in North Carolina at Wake Forest University School of Medicine. He's also an author. He has written a book. He's written actually 8 books. One of them is a book entitled Bedwetting and Accidents Aren't Your Fault. We're going to talk about that book as this podcast continues. But Dr. Hodges, welcome to the Hamilton Review.
Thank you so much for having me. I appreciate it.
It's my pleasure, and look forward to our conversation. So if you've listened to my podcast, you know that I like to start by asking my guests to introduce themselves, to tell our audience a little bit about who you are, your background, and how you found your way to becoming a pediatric urologist, which, by the way, friends, is not a gigantic. There aren't a huge number of pediatric urologists in the United States. Steve, how many are there actually out there?
Oh, yeah, total? I don't know, but I'd say North Carolina, there's 3, 6, maybe 9.
In
So
the
yeah,
in the
in North
entire
Carolina.
in the entire state of North Carolina.
Yeah, yeah,
Okay, so you multiply that out by 50 states. We're talking about hundreds, not thousands, certainly not tens of
right.
thousands of pediatric
Yeah,
urologists. So
definitely.
these are rare people. So Steve, Dr. Hodges, thank you for taking the time to be here today. I mean that. So tell
Thank you.
us your story.
All right, so I'm a Winston-Salem lifer. I'm born and raised here, the son of Greek immigrants. Came from a poor village after the Civil War, after World War II, kind of ravaged where they grew up. And so got a dad in the restaurant business, as you can imagine. And then was able to luckily go to Duke University undergrad, enjoyed that, and then came back home to Wake Forest University for med school. And, I like to say no one ever grows up wanting to be a urologist, I don't think. I didn't know what a urologist was. And so when we picked our electives for third year, the clinical clerkships, there was a urologist I knew who happened to be another Greek guy from Chicago that was a member of our church, Dr. Dionysios. And I said, well, I'll go work with him. That'll be interesting. I know him. And so I got in the lottery. I got a urology rotation, and I fell in love with it. And did all sorts of urology, but there was also a peds urologist here at the time, Dr. Larry Cruvan, who's since passed. And he really got me interested in pediatric urology. So then after I was able to get a urology residency at Wake, and that was a 5-year process. I then did a fellowship in San Diego. Did 1 year in San Diego clinically, had a great year with Dr. George Kaplan, and then came back to Wake, did 2 years in the lab with Dr. Tala, my current boss, and then started practicing. So after that long process, and as you know, urologists are surgeons by training. It's primarily what we do. See people in clinic mostly to prepare or to follow up from surgery.
Yeah.
But we also have a significant portion of our population that has voiding dysfunction or bowel and bladder dysfunction, which includes bedwetting, daytime wetting, urinary tract infections, and so forth. In most centers, I would say in the United States currently, these problems are taken care of by physician extenders, PAs, nurse practitioners. They do a fine job with kind of the cookbook approach to that. But I was seeing most of these kids on my own in clinic just because we didn't have any physician extenders. And I was using the traditional cookbook methods to treat this problem, and was having underwhelming success. I really, you know how it is. You get into medicine, you start doing the things you were taught, and it either works as like you was told or doesn't. And so I was seeing that this stuff just wasn't working as well as I wanted, and I felt bad for the kids and the families that they were having these continued accidents. And I've told this story a couple times, but I think it's worth repeating. Series of kind of fortunate events for me happened all in sequence that led to where I am now with this practice. I went to Cincinnati Children's Hospital for a course on anorectal malformations and cloacal anomalies for repair, given by Dr. Alberto Pena, in which and his associate, uh, Dr. Mark Levitt, who's now at DC. And what I learned at that course, among all the surgeries, was that they were following kids with constipation with X-rays because in their profession they need to make sure the kids get empty um, when they have bowel movements, either with enemas or whatever, to maintain continence because they were born with certain conditions. And I said, that's interesting. I'd never done X-rays for constipation before. And then I came home, operated on a kid the next week for kidney reflux that had such a full rectum of poop that the surgery was difficult. The bladder was being pushed out of the way. Um, After the surgery, went back to the parents, said, this child's been pooping well. She's like, no, perfectly, never had a problem in their life. And I was like, wow, it's a disconnect.
Sure. Yeah.
I'm gonna start getting X-rays. Um, got X-rays on all my kids in the clinic. Found all of them had extreme amounts of constipation. Asked the parents, are they pooping okay? They all said they're pooping fine. So that's why I decided I'm not going to ask parents anymore. Well, I'll ask them, but I'll get the X-ray anyway. And I found that they were all full of poop. I would fix the poop, and the problems would go away miraculously. I mean,
Ama-
bedwetters were getting better. I was treating people left and right and getting better. Sent my resident on a mission to write this up. I thought we were going to change the world. We discovered something amazing. She calls me back. She says, this was written about in the 80s. There's
Hmm.
a bunch of papers on it. I don't know why we don't know about it. It's by Dr. Sean O'Regan. He was a nephrologist from Canada. I spent the next few weeks trying to find Dr. O'Regan. I found him on the phone. He was living in Arizona, retired. And I said, Dr. O'Regan, you did all this work and no one knows about it. He goes, I know. I'm glad you found it. And we've kind of tried to bring it back to the forefront. And he's been very helpful. And the rest is history, as they say.
Yeah. So first of all, let me just comment that you're right. There's nobody actually grows up as a kid saying, I'm going to be a pediatric urologist. So I
Yeah.
I can verify that for sure. I just want you to know that. Number two, what you're saying here is you wrote this book, The Bedwetting and Accidents Aren't Your Fault. So what you're saying is that constipation, and we call this encopresis. These kids really get their rectums and their sigmoid colons can get literally stuffed full with poo. Why did the parents? Because I mean, I certainly deal with a lot of constipation in my practice. Usually, parents will give you a story that they do have infrequent, or when they do have a bowel movement, it's hard, or the bowel movements are extremely large. Are you saying that there's a lot of constipation going on out there that is being unrecognized by the parents and also by us in the practice?
I would say the vast majority is unrecognized. If you look at the pediatric urology literature, they'll blame bedwetting on 30% of kids with constipation. They'll blame it on that. I've seen way higher numbers. And to your point, the most consistent symptom I do see, if you really ask, is large bowel movements. But the rest of the Bristol stool scale or the Rome criteria, most kids don't have symptoms. I do think I'm selecting for kids that just have bladder symptoms mostly. And so if they had bad bowel issues, they might have seen GI first and treated. So I'm selecting for kids that were able to kind of delay pooping in a way that didn't raise anyone's attention. And it is interesting. It's difficult to bring that up with parents in a way that doesn't make them feel like, what's this guy talking about? My child's never had trouble pooping. I came here for a bedwetting problem. And so that's where I do find the X-rays are helpful because um, when all parents say, that the vast majority, he's pooping great, never had a problem. We look at the X-ray and they're like, oh wow, and they really get on board. But yeah, I would say most functional constipation is missed, but with a caveat that the semantics is very important. Like, what do you mean by constipation, right? So when I had that first conversation with Dr. O'Regan, I said, these kids, people don't know they're constipated. And he goes, yeah, the problem is, Steve, it's not what people consider constipation. It's incomplete emptying of the rectum. And that was a very, I think, intelligent way to put it. So by delaying defecation voluntarily, you overstretch the colon and then you can't empty.
Yeah.
It's
Yeah.
like, for my cardiology friends, I call it left heart failure of the rectum. You know, it's like a cardiomyopathy, hypertrophy. It just can't squeeze. The Starling curve is all messed up. So yeah, it's sneaky. And X-rays are very important. And you know, we all believe what we believe. We all have biases, but I'm open to anything. So every time somebody comes in like, no, my kid's the best pooper ever. This can't be it. Maybe it's something else. I'm like, well, let's check it out. You know, I get an X-ray, and 99.9% of the time they're full of poop. So.
So when you have a kid who comes in and they're coming to your urologist, most people don't make appointments with urologists. So something's going on. They're having encopresis, which means that they're pooing in their, without knowing it sometimes, and they're having enuresis, they're having bedtime wetting. What do you do for these kids? So you obviously you have a situation. How do you get these kids to the point where their colons now have the ability to empty completely? What's that
Well, yeah,
process look
yeah,
like?
yeah. I'll say that this is a very the setup of this is a very immature process, right? Young infants, children that don't know any better will delay pooping. You know, most older kids will do better, but the older kids they appear to be pooping on time because they're responding, but they're kind of the baseline of the rectum has been set too large, and so they can't recover unless they really get empty a lot more than they're going regularly. And so, and I do break up the accents like you're saying into kind of three types, like nocturnal enuresis, bedwetting, and then diurnal enuresis or daywetting, and then encopresis. Some kids just have the poop accents, and I'm seeing a lot of those now just because I've gotten a kind of reputation for treating these issues. But some of them have just bedwetting, some of them have just daywetting, some of them have all three. And you can imagine the more accents, the harder and the longer it is to get them empty. But when I started treating them, I use Miralax because I'm not a urologist. I mean I'm not a gastroenterologist. I'm a urologist, so I didn't have much experience treating constipation. I used the simple stuff that everyone used, and I had some success. But when I found Dr. O'Regan's work, and I realized that he was doing enemas, and he had great success. I jumped once I checked the safety and the proper uses of enemas. I jumped to that real quickly, and that's been much better for me. But I have a series of protocols. That we have a book called the M.O.P Anthology. It's the 5th edition now. Where we've taken M.O.P stands for the Modified O'Regan Protocol. So O'Regan's protocol was an enema every night for a month, and then tapered over 2 months. Every other night for a month, and then twice a week for a month. And he had an 86% cure rate for nocturnal enuresis, and he swore to me the kids that didn't get better weren't doing enemas. So maybe, but I've seen a much larger population now with much more significant, um, not only accents but also degrees of constipation. So we modified the O'Regan protocol because we found rapidly that 1 month might not be enough. But to answer your question more succinctly, we have several regimens of combining oral and rectal therapies to empty the poop when the kids don't feel it, empty them as rapidly as possible, and keep them empty so the colon can shrink back down and they'll regain the sensation. And assuming they go poop when they feel it, they would be fine and they can get dry pretty quickly.
So the period is relatively short, a month to 2 months. It sounds like that you can shrink it down, and then basically, so what happens is that what you're saying is the rectum and essentially gets acclimated to being distended, and
Yep.
it doesn't respond to normal collection of stool in the rectum, and therefore it is not responding, and it doesn't have the ability, it doesn't have the ability to empty completely.
Yeah, 2 points. The 1 month was Dr. Regan's protocol for just bedwetting. So, because I know I have a lot of kids that are on a lot longer than a month, and I want them to feel upset about that. The, I would say that if you start off with more accents, it takes longer, even bedwetting. But the key is to get empty. So I've done 1 month enemas in a kid. They never got better. I X-ray them again, and the X-ray looks the same. I can't explain it. You just have to find the right protocol. So it's possible to get them empty and as dry in as early as a month with bedwetting, but if you have day wetting as well or day symptoms and encopresis, it will take longer. But once you get them empty, they do fine. And yes, people know, kind of intuitively that if you overeat a lot, your stomach stretches. It takes more food to feel full, or the converse, that if you do stomach stapling or shrinking the stomach, then you get full sooner. Same thing with the rectum. If it's always overfilled, how do you know you're full? And the other issue with the rectum, different than the stomach, is that there's a geographic limits to how wide the rectum can get. The pelvis is limits the how the dilation of the rectum can exceed. And so a lot of the kids I see, the whole rectum is full of poop, and so the pelvis couldn't get any more full. So where's it going to go? So they don't have any sensation. And the only reason they poop is because someone has them have a potty sit, or maybe it falls out, like you mentioned, in encopresis.
Yeah. So when kids are having nighttime wetting, we call it nocturia or enuresis, what you're saying to me is you gotta check and see if they're constipated. And I frequently listen. I have been treating normally when you have early on when the kids are 4 or 5 years of age. I don't really treat those kids. I usually look at it as being a neurological phenomenon, that nerve that goes to the brain to the bladder is really not wired. But what you're saying is you need to, in kids even that age, you're saying that you need to really look, do an X-ray and look.
Yes, Dr. Regan treated his own son. That was his first patient. That's what got him interested in this. He treated his son at 4 years of age, found the problem and treated it. So I do think, again, it's very common. I don't push treatment at 4, but 5 years of age, I don't like to sit on too long, because although bedwetting does go away at a certain rate, um, some kids have been told to watch it for 10 years by the time they see me. But to your point, I do our theory consists of 2 voiding systems, right? The infantile voiding reflex, which is how infants void, which is like a pelvic reflex, and then the adult voiding pattern of the signal gets up to your brain and you wake up, or you feel it and you go pee. We believe that the infant voiding reflex, although it goes away as you age, it persists abnormally if you have rectal dilation, and it fires that off. And so our theory explains why bedwetting doesn't arouse anyone. It's not deep sleep, it's nothing like that. The signal never gets to the brain. It's a sacral reflex. It's a loop. And so even though some signals do get to the brain because that path's developing and it exists because these are neurologically normal children, this sacral reflex is dominating it because of the rectal dilation. So the sooner you can get that rectum shrunk down, that reflex goes away and they can void normally.
Very interesting. Do you ever use DDAVP?
I do. I have like a 3-step protocol now, which is bowel program, and it's onerous, right? It's a difficult program, so you can do what you can do, and then I will do medicines if they're getting empty and they're not dry yet, and they're kind of in a hurry. I have noticed, I haven't written this up yet, but I need to, that if you start the medicines first thing when they're really backed up, way less effective than if you start the medicines after they've emptied out quite a bit. And why is that? Is because this is all the root cause is this rectal dilation causing this reflex, but it's multifactorial, as you know. It's like how much did you drink? How fast did you drink it? Because if the bladder's filling rapidly with a lot of fluid, you're more likely to set off that reflex than if you have an empty bladder. So desmopressin can help, but that desmopressin has a poor success rate, most kids. And so if you can get them empty, it works a lot better.
Very interesting. Well, you are you also have comments about a thing called attachment parenting, and I'm curious. I'm not sure how this fits into your whole issue of accidents and bedwetting, but can you kind of speak to that issue? I know this is a specialty of yours as well.
Yeah. So when we got into our theory, or kind of treatment for bedwetting, what were we treating? Right, we were treating this rectal dilation. So we were treating children that had delayed emptying for a long time and gotten really filled. And so we developed some theories that this is potty training in general is giving a young child 2, 3 years old, maybe younger, this responsibility. And they don't understand the importance of going to the bathroom. You couldn't even explain to a 2-year-old that when you feel like you have to poop, you better go poop, right? They have no idea. So we theorized, because we saw these issues that were worse in kids that were trained very young. Um, UTIs were showing up in little girls only after potty training of certain type. That wow, that something about potty training, or potty training when a child's not mature enough to know what they're doing, is detrimental to pediatric health. They'll have more accidents, they'll have more infections, and so forth. So we got on a push of late toilet training, child led. When you can talk to them about it when they're 3.5, know what's going on. And so we've been big proponents of child led and kind of slow at a child's pace later bedwetting to a point, right? We don't want to have 5-year-olds in diapers. You have to train at some point, but you can talk to a kid when they're a little older. Say, hey, when you poop, make sure you go. If you feel it, is your poop hard? You can have a better discussion. And we had a lot of pushback by the elimination communication parent groups, which were involved in this attachment parenting, where they don't like to use diapers, and potty training a child at 6 months. They're pretty sensational stories are out there every once in a while. A lot of celebrities seem to like it. And I don't care how a kid pees or poops, or when they pee and poop, as long as they go on time. So early on, I was more dogmatic about when you should potty train. Now I've learned that the earlier you train, you will get backed up more. That's true. But if you're prone to withholding, it can happen at any age. And certain kids that get backed up will have accidents, and certain kids don't. So you could have good genetics and not have that problem. But in general, I think it's better for kids to kind of go slow. I understand what the attachment parents are trying to do. They're trying to create more primitive, healthy lifestyle. But if you think about how primitive children peed and pooped, it was probably whenever and wherever they wanted. It didn't need a toilet. It didn't need to take off clothes. So I think keeping them in diapers is more consistent with primitive behavior than actually trying to potty train them early.
Yeah. So when do you recommend? What age do you recommend potty training?
I like 3.5. I think 3 is too young. Right when they turn 3, I think 4 is too old, because they should know by then unless there's an issue. So every kid that I've dealt with by 3.5, assuming they're not constipated, potty training comes pretty easily.
Do you see a difference between boys and girls in potty training?
Not really. I know there's a lot made up of that. The only issue I see is if you wait till they're older, they can get comfortable pooping in a pull-up. And so then it's harder to get them to poop in the toilet. But there's ways to fix that. But yeah, I have some kids that, a lot of kids I see that, okay, we trained them, but they pee fine. But every time they want to poop, they ask for a pull-up, and that's understandable. They're just kind of used to it.
3.5 is an age which seems to be a little bit older. I have to say, when I hear that, I think that's a little bit. I'm going to have to kind of check with my colleagues and find out when they're recommending it. But I know that there are kids who are potty trained. I mean, I spend a lot of time in the third world, so I can see kids who are younger. I mean, who are 2 years of age, who are definitely potty trained, say in Africa. And I think that possibly is out of a point of necessity, that the parents do not want them, having accidents whenever they're out and about. So anyway, interesting. Okay, I'll have to rethink that, my recommendations.
And again, I've softened that up again, because if you have a family of history of bedwetting and they get backed up, then you're going to have bedwetting. But if you don't, they're going to get backed up and no one's going to know. And also, there's nothing to say that if you trained a kid at 5 and you didn't make sure they pooped on time, that they wouldn't get backed up. But the developing nation argument is interesting, because a lot of these kids, like for example, the split pants in China was brought up a lot. Well, these kids in China are trained so young, but in reality, they were allowed to pee and poop anywhere. They were allowed to pee and poop on the playground, in the grocery store, because they had this split pant. So I'm agnostic now to any potty training method, because I realized it was a kind of a philosophical religious debate. But I am a bigger proponent of on-time emptying. So whatever gets kids to empty on time and completely, I'm okay with.
That's your thing. Okay, I'm watching our time here, and watching your time, Steve. I have one last kind of question I want to pose, and that is the whole thing of circumcision. This is I find that in California, we're having more and more people who are opting not to do it. And I'm just curious on your take from a pediatric urologist perspective on circumcisions in boys.
Yeah, so we've always been taught in my profession that the lifetime risk of circumcision and non-circumcision is equivalent. It's about 2%. If you have a circumcision, your risk of complications is at the time of circumcision, which is bleed or adhesions and so on and so forth. If you're not circumcised, your risks come later, either with phimosis or balanitis, or old men sometimes get paraphimosis. We have lots of consults with old men in nursing homes with mismanaged foreskin. So we've always said, family choice, whatever runs in your family. Recently, with increasing data that circumcision prevents penile cancer, prevents and lowers the risk of STD, specifically HIV, it has become, I'd say, maybe more recommended. And I say that not from like that we go out pushing it, but that it's been covered by Medicaid in North Carolina where it used to not be. So obviously, the powers that be have decided that maybe this is beneficial for pediatric health. But again, my general rule is family choice. We can manage it with or without surgery. It's up to you. All the complications that happen due to circumcision not being performed usually can be managed with medical therapy.
So interesting. So you're agnostic. You're not pushing it one way or the other.
No, I think, it's funny because it's very cultural. We see a lot of Latin American population that are very anti-circumcision, but other population, I think the kind of white American population is about 60-70%. Obviously, Jews, Muslims have religious reasons for it. So it's an interesting bit of history. I would tell families, kind of your choice. Understand the risks and benefits and choose what you feel comfortable with, and you're right either way.
Yeah.
My answer.
Okay. Well, that's my answer too. I'm pretty much agnostic. I tell people, because of what you just said, I am 51% for it, 49% against it.
Yeah, right.
Which
That's
is
exactly right.
maybe
Yeah,
like
there's a slight benefit.
1%. Maybe I could increase that to 2% based on what you're saying. So the complication 2%.
Yeah,
Okay.
right.
Well, listen, Dr. Hodges, you have been a delight to talk to today. I'm watching my time because I know you're on a time frame as well. We're gonna stop it here. So let me ask you a question. How do people find you?
Yeah, I would encourage people, if they're having any children with any kind of pee or poop accidents, to look at our website. It's www.bedwettingandaccidents.com. That's bedwettingandaccidents.com. I think we have a world-class program built up there. I think we have some great data. I've really honed down our bowel program. We have a lot of options, and have had very high success rates for nocturnal enuresis, daytime diurnal enuresis, and encopresis. So definitely seek us out if you need help.
And your book again is called Bedwetting and Accidents Aren't Your Fault. Your publisher is that on that is who?
We published, so the first book ever published was called It's No Accent,
Okay.
and that was published with Globe Piquot. Every other book has been published, self-published by O'Regan Press. We threw a shout out to Dr. O'Regan. The Bedwetting and Accidents Are Not Your Fault is to help prevent abuse of children and psychological despair in these children that are having accidents, because we know that happens, and to show them why these accidents are happening. And then we have the M.O.P book Anthology, which is our most up-to-date, as I mentioned, the 5th edition of our animal protocols to fix accidents as fast as possible. Because from the first M.O.P book to the 5th edition, we have modified our treatment based on real-time feedback from our Facebook page and parents out in the field, and my clinic as well.
So how do people find your book?
All the books are on the website. They're linked there, or you could just Google Dr. Steve Hodges. But the easiest way is to go to www.bedwettingandaccidents.com. All our resources, getting in touch with me, and all the books published are available there, as well as a blog with we put out regular articles on topics of interest.
Okay, so it's called Bedwetting, and the word "and" spelled out.
Yes, sir.
Accidents.com. So there is where you get a hold of Dr. Stephen Hodges. Well, friends, Steve, I would just want to say thank you for taking the time to be on the Hamilton Review today.
Thank you so much. It's great.
It's been great. And friends, those listening, thank you for joining us today for this interesting conversation. And thank you for tuning into the Hamilton Review. I appreciate it. Until next time, be well. Bye-bye.
You have been listening to the Hamilton Review, where kids and culture collide. Thank you for allowing us to be a part of your day. Tune in again next week on Apple Podcast. Rate and comment and tell a friend.